shall we go on to the next session? I'm Dr. Man from Pathology, and I'll be the moderator for the second session. First, I just want to thank Dr. Chiu and Dr. Sato for such a good and informative talk. For my session, it's nothing about pathology, even though I'm from the Department of Pathology, but instead we're going to learn a bit about the care of those facing death and dying, all right? Now, managing this stage of life is very difficult and delicate, and as doctors, we all face dead patients, dying patients, not only the patients, but their families. We pride ourselves on being able to handle their crisis as well as our own mental health. And sometimes it's even worse when we are faced with our own mortality. I mean, eventually we all will, have to meet our maker and the mortality of our loved ones. So it's very difficult, all right? So I just want to get this little talk done so that to help us navigate this topic. And I would like to introduce my friend who, despite his youth, Mr. Ethan Ganesh, he's already has extensive experience in the field of palliative counseling. Now, a few words of introduction. Ethan is a licensed and registered counselor. His interest in palliative care began when volunteering with crisis helplines, where he frequently received calls from individuals facing life-limiting illnesses and grief. He has worked in community hospice setting, where he has witnessed firsthand how multidisciplinary care can improve the quality of life for dying patients, all right? And this has solidified his passion for palliative care. Ethan has since gone on to champion mental health and palliative care, and he has shared his experiences with many, many people, most recently at a conference in Sri Lanka. Today, he will focus on exploring and conceptualizing mental health distress in those facing life-limiting illnesses. So Ethan, you have the floor or screen. Okay.
Thank you, Dr. Man. Now imagine you've lived a wonderful long life of 82 years. Everything seems to be going great. You've achieved so many life events that you never thought you would. All the goals are achieved. But then suddenly at age 83, you get a diagnosis of cancer and the doctor tells you it's metastatic. All of a sudden, your life starts going downhill. The symptoms, although they're managed, you find that you're not really yourself anymore. You find you can't do the things you want to do. And although technically on paper, you should be feeling okay, the fact that your life has changed so much makes you wonder, what did I do to deserve this? And when your family, although they've always been loving, comes up to you, you find that things have changed. They're not so sure how to interact with you anymore. Although they want to speak with you, they feel like they're not quite sure what to say. And sometimes you get the sense, what if they're just waiting for me to pass on? You lay back and you rethink about your life and you begin to wonder, was there just something that I did to deserve this? What did those 82 years mean at the end of the day? Ladies and gentlemen, hello and welcome to my talk. And before I welcome you to the talk, welcome to me. As Dr. Man so kindly introduced me, I'm a licensed and registered counselor. And although there are many different things that I do, and currently I work in the private setting, I've had experience working in the palliative setting and watching how we care for people at the end of life and how we observe, what our final days can do, how that makes meaning of what we've done in our lives has really inspired me to be here and to advocate for how we can do better for really all our loved ones. So starting us off, I know we all love definitions. This was taken from the World Health Organization, but our Ministry of Health has a very similar definition. So palliative care is an approach that improves the quality of life of patients who are facing life-threatening illnesses. Ideally, it prevents and relieves suffering through early identification, correct assessment of pain, and of course, dealing with the physical, psychosocial, and spiritual. Now, all this to say, really, when we think about taking a palliative approach, what we mean to say is we want to understand that when someone has a life-limiting illness and is at the end of life, the experience of pain is a whole overwhelming experience. So that means it affects so many different aspects of our lives, from the social, the spiritual, the physical, and emotional. And I think this is not something that's very new to most of us. And especially if you work in the palliative setting, you would have heard of the term total pain, right? And it's all about us trying to understand the different angles at which we are impacted and what suffering and that experience looks like in a palliative end of life care setting. Now, when I first started, I think it's so new, right? And it's difficult to see how it applies so universally because the end of life is the end of life, right? Except things change over the years. And one of the good pieces of news is also a challenging piece of news. So we all know that we live longer, the life expectancy is increased. This is a stat just to elucidate that fact. But what happens with living longer? Now, with living longer, of course, there's a higher likelihood that we'll face life-limiting illnesses. And this was the least traumatic image of cancer that I could find. But whether you have cancer, neurodegenerative issues, organ failure, frailty, stroke, or other life-limiting illnesses, there is a higher likelihood that you will get them the longer you live. Now, what's challenging about this is living longer means that end of life is a part of life. We now know the natural cause of our end of life. It's not in those days when we used to say we're just getting older. Now we know something is happening to us. In addition to that, there is now a fear of dying. Now, not the fear of death, because many patients that I speak to will say they could go anytime. The bigger fear is actually the process of slowly losing function, their relationships, and passing on. And with that, of course, means distress at the end of life. The emotional and psychological distress is something we don't often talk about. So let's talk about that today. So let's talk about a familiar distress, depression, major depressive disorder. I want to talk about a study cited by ESMO. And ESMO looked at a study of more than 20,000 patients. And they looked at them and they tried to figure out how many of them would meet a diagnosis for MDD. And they found that 7.5% of those who they screened had MDD. But the bigger challenge is how many of those actually got mental health support? And that's where we find the number is pretty abysmal. So you only have about 74 out of 20,000. That's an incredibly small number. And I think all of us know as healthcare workers, it isn't always the major depressive disorders that are what patients struggle with, right? There's often more to it in the background. And another common experience that you will find is when someone is at the end of life is something we like to call desire for hastened death. Now, this is different from suicidal ideation in the sense where someone who has a diagnosis of a life-limiting illness has a time limit, so to speak. And what happens is they want to stop treatment, they may ask to accelerate or wish for an accelerated disease progress or get some help to hasten their own death. And what makes this so unique is the person wishes to control the circumstances of their death. So it's not as straightforward as it seems. And to give you a very simple example, talking about the prevalence, right? So in patients with advanced diseases, the range is pretty big. You can find it in 1.5% of patients to 37.8. It varies across advanced illnesses. The highest ranges would typically be among advanced HIV and AIDS, whereas the cancer is about the mid 20%. So that means about a fifth or a quarter of patients will express some desire to pass on, to die earlier than their disease. And it's very complex. I will share with you why it is so profound and challenging. So I remember the first time I got a chance to work with someone who showed this. I had a conversation with an elderly gentleman in his 60s, and he was telling me how he had cancer for the longest time, and he now reached the late stage. The doctors told him there's nothing he can do for him. He'd used up all his money. He felt so useless. He used to be the provider of his family, and now it's come to a point where he feels like he can't do anything for them anymore. So you shared with me, my family doesn't want to see me. They feel ashamed of me. They leave me alone in a home. And, I don't know what to do. And as I'm sitting and trying to understand him, he suddenly starts to get very frustrated, because I'm asking how he feels and all these generic questions that, I used to ask before. And he would say, you know what do my feelings matter? At the end of the day, I'm going to die. Why don't I just stop eating my food? What's the point of taking care of myself? Or you know what? The next time I see the doctor, I'll ask him to start giving me more medication. And if he doesn't, maybe I'll stock up the medication so that I can take it and just end my life. And I remember being so profoundly stuck because I would ask myself, in my early days, well, if I were in his shoes, I would certainly feel similarly. I don't know what to say. And if you'd see, he would express all these things. He wanted to die now. What's the point of taking care of myself? Maybe I should overdose or store my pills. And so I think one thing that I'd like to do for us today is to talk about palliative care and think about palliative care and mental health and think about how those depressive symptoms, that desire for hastened death is really a cry to be understood deeper. Because when it comes to end of life and life-limiting illnesses, there is a trajectory, there is a prognosis, there is an end. But how can we be more attuned to the feelings and experience of those at end of life? And how can we have more intentional and compassionate conversations with those who are terminally ill? To break it down, the real question is, how do we open doors to even begin? Now, I think why this is so important is because if anybody has worked with patients in a cancer ward or with, let's say, motor neuron disease, I had this told very directly to me, and I found it very funny because all the survivors and patients that I worked with have basically mostly said, don't ask me, how are you? That's one of the most frustrating questions. How am I? I'm bad. What else can I say? So what I'd like to share with us is how do we open doors for conversation that allows us to explore what that distress is really like or which areas those distress are coming from. I'd like to propose that there are three key areas: the illness, the social, and the self. This is based off the dignity model in the terminally ill. And don't worry if it doesn't seem so clear at the moment, I'll break it down in a case a little bit later. But very basically put, when we talk about exploring the illness impact on the individual, we talk about factors that derive from the illness and how this affects the person. For example, earlier in the old man case, the person says, my feelings don't matter because there's nothing I can actually do. The illness makes me feel this sense of hopelessness because I can't actually function, I can't get out of bed. And when it comes to this person's view of themselves, what you'll find is what's important is us exploring how, as patients, as people, our perspectives of ourselves has changed because of the illness. And so this old man used to tell me, I was the provider of my family, I was the one they depended on. Now, what am I? And finally, we want to talk about the social. So the social is important because we want to know what are the external factors. Things change when we get sick. I think everybody knows that. But we need to explore that. In what ways was the person affected and how does this impact their mental well-being? So in this case, the old man just now was saying, my family doesn't visit anymore. They put me in this home. I feel like I'm already dead to them. So not to worry, let's explore what this looks like. The reason why I propose we have these areas in mind is because when we are able to intentionally explore with the patient what their experience is and what their mental well-being is like, we are able to extend empathy through that exploration. Oftentimes, you'll find that many of our loved ones are already thinking about a lot of these things, but it's stuck and they don't have a place to ventilate clearly. So let me introduce you to Mr. Lee. Now, this, of course, has been anonymized, details have been modified for anonymity, but Mr. Lee was a 74-year-old man with advanced heart failure, and his symptoms were controlled. But the funny thing for us was when I was asked to see him, is technically he could get out of bed. He could get on a wheelchair, he could walk around the room, yet he chose to remain confined in bed. Most times he had a very cheerful demeanor, but whenever his family or the nurses or the doctors would ask him, why don't you try and do some exercise? He would suddenly react very angrily and he would refuse to even talk about it. So I was called in to kind of try and understand the situation more, see what could be to help Mr. Lee feel better and address those outbursts. So let me tell you about how we explored those three dimensions with Mr. Lee. So I remember when talking about the illness, I think this is the most straightforward area, right? So we came in and I remember asking him, oh, Mr. Lee, nice to meet you. The conversation was going really well. We were just breaking some ice. And Mr. Lee, when I saw him, was hilarious. He would talk about the dyspnea, the breathlessness, yes. And in fact, he would joke about it. He would suddenly say, you know what, Ethan, I'm so tired. You know what, maybe I'll just take your heart, And I would laugh because this guy is hilarious. And a part of me started to wonder, I heard that he's struggling, but he seems so happy. And I thought, oh my God, should I ask? Should I ask? And I know we all tend to feel this way sometimes, but I said, okay, what the heck? Let's ask. Let's do the brave thing. So I say, Mr. Lee, I heard that you can get out of bed, you can technically go around, but every time your family brings it up, I notice that you get a little bit angry. I wonder what's going on. And then he gets really frustrated suddenly. He says, you know what? You're asking me to get out of bed and do all these things, but let me ask you a question. What is the point of even getting out of the bed if the only thing I can do for myself is turn off the lights? What's the point? And that's a key area of illness that we want to address, which looks simple on the surface, is a sense of independence. Independence is, when we refer to independence, we talk about the degree one is able to avoid feeling reliant on others. Now, on the surface, it sounds simple, but an important thing to ask is, let me suggest some questions for us. First is, in what ways has losing your independence affected you the most? So I asked Mr. Lee, speaking about this, it sounds like you feel like you can't do much for yourself anymore. What bothers you the most? And then he lets out a sigh and he says, well, actually, none of this really matters. But what really bothers me is that I can't play with my grandkids on my own anymore. When they want to run around, I want to be on my own, take care of them, have fun, and I can't do that. And when I asked deeper, is there any particular area about this that you miss? And he goes, I miss playing games with them. I miss engaging in the routines that we used to have as a grandparent. And I think all of us, if we're grandparents, can imagine the joy that that brings. And of course, we want to ask, if you get help from others, do you find it difficult to accept it? And if so, why? And he mentioned that, yes, it has been a struggle. So as we explore this sense of independence and what aspects of it he feels he has lost, we realized that, hey, maybe we can bring the grandkids in, but allow him to do activities that he can still do with them. So for example, by the bedside, any games like drawing, board games that he can play with his grandkids, that allows him to feel like his independence is still intact. He doesn't have to feel supervised when he plays board games, and that makes a world of difference. And then we talk about the self, right? So it was important for us to also explore with him how that's changed. So I asked him, because there's still an opportunity for him to get out of bed. So I asked him, what would you do? What would be important for you if you got out of bed, if you were able to do that? And he said, get out of bed? I can't even imagine doing that. What is the point of doing that? And he looked at me and he said, what is the point of getting out of bed? I'm just a sick old man. And this oftentimes is what we refer to as role preservation. When someone reaches that phase of life, they want to maintain a sense of dignity and congruence with how they used to see themselves. So Mr. Lee, from what I understand, was actually very often the life of the party. Many of his friends loved him, the family around him used to make them laugh all the time. But unfortunately, when he's gotten to this state, he feels like, what's the reason to make people laugh? Every time they come and see me, all they talk about is death and dying and how much they're going to miss me, my symptoms, my medications. I can't even feel like myself anymore. So we said, and one of the first things that occurred to me is, we asked him, Mr. Lee, and I know you feel this way, but I want to ask you, you just sat in a room and you made me laugh. You made all the nurses in this room laugh. What does that mean to you, that you can still do that? And I noticed that Mr. Lee took a step back And he seemed to be thinking, you know, maybe there are still some parts of myself that I can still engage with. And I think this is specifically important for us to hone in on, because we all know that roles change as we lose function. But what we need to hone in on is, what are the specific things that you did before you were sick that are important to you? And, you know, questions like, in what ways do you still feel connected to your previous role? Or maybe even, what are the identities that are still important for you to preserve? So the identity of being able to engage others, make others happy, it was so important to him. And just because he can't move around doesn't mean he shouldn't be able to do that. So I remember asking him, you know, you enjoy this so much. I wonder if it's fair to you to stop enjoying this, even when you're sick. I'm sure it's important to you to enjoy this. And he goes, you know what? Maybe I'll consider it. And why this was important is because it created an avenue for him to consider how he could still be himself. And now finally talking about the social. So I did ask, you know, finally when he talked about when we talk about him reacting and having outbursts when his family offers to help him, his family had gotten very frustrated because he would often seem so annoyed whenever people offered to help him clear his plate, wipe his lips, so on and so forth. And he told me, you know, I get so angry because I feel like such a tremendous burden to others. All I am is someone to take care of, and I feel so useless. And this feeling of being a burden, I think, is something that I really want to highlight as something that we should look out for as healthcare professionals, because the aspect of feeling burden to others in the study by those who use the dignity model is found in about a quarter of those who are terminally ill. But what is more important is in those patients who actually wind up ending their lives. This feeling of being a burden is cited as being almost universal. So finding out if the patient feels like they're a burden to others is incredibly crucial in deciding how intensive we should be when we approach the cases. Now, when we explore being a burden, some questions that we can ask are, do you worry about being a burden to others? In what way and why? And this is important to ask because some people are okay with being cleaned and whatnot, and they see this as a normal experience of aging. But they might feel like a burden when it comes to their family having to feed them. It differs from individual to individual. We want to find out specifically in what way they feel like a burden and how we can address that. And of course, we want to ask, how do your loved ones respond when you express this concern? Because when I did ask, Mr. Lee finally said, oh, you know, actually, they're very understanding and they're very nice. It's me, you know, I feel so angry and frustrated. And what I asked Mr. Lee and the family is, would it help if your family reassured you once in a while that they do this because they love you and they care for you, and this is important to them, they take joy in it? And Mr. Lee said, you know what, um, that's okay with me. I think that will help. And at the end of the day, I think a lot of changes that we saw in Mr. Lee, when the next time we would come in, he would take note of all the things that we liked, our favorite kuehs, our drinks, and he continued finding ways to be himself. Even though there were times when he had outbursts and he was frustrated, he still got to feel like himself in the final phase of his life. Now, so this is my suggestion to you. We talk about the desire for haste and death. We talk about the depression, but when it comes to the experience of your well-being at the end of life, how can we help people feel understood? And I propose that we can explore where that distress comes from by exploring the illness, the self, and the social in the patient. Now, of course, this is something that takes experience and practice, but I've left those slides as a suggestion for areas that we can explore to help us find out how we can better attune to the patients. Of course, this is based on a model by Harvey Chochinov, psychiatrist working in Palliative, the dignity model for the terminally ill. Of course, I rephrase some of the words because nobody wants to run around asking their patients how their dignity-conserving repertoire is doing today. I think they might ask for a referral to a different doctor. So I leave this for you to utilize. And I want to very quickly close with this. In the recent months, I've had the experience of visiting hospices in Sri Lanka, and these are the picture of me with the nurses. And I even managed to visit a CC hospice in Singapore. And going there and experiencing, although there are differences in services and facilities, at the end of the day, every doctor and nurse that I spoke to shares the same feeling. Life is a pre-existing condition. When our patients come in at the palliative stage, we want to honor the life that they have lived. And I think this is so important because when we go out in the field, we find that even as healthcare professionals, when our parents get sick, doctors and nurses have told me that all they want to do is be their parents' child again, just want to be your father's son again. And I think this is so crucial. And I hope that being able to explore these areas of mental well-being gives us a way to help our loved ones feel loved, even when they don't feel lovable anymore. And I think it's a long way to go. I hope that we can begin in Malaysia exploring well-being and palliative mental well-being. I'm in the midst of bringing together counselors and clinical psychologists to see if we can come up with referrals, peer supervision, and further support for those of us working in this field. So if you know anybody who's interested and you would like to work together on something, please get in touch with me. Do let me know. I'd love to be of service. And thank you for having me.
Thank you, Ethan. That was a wonderful talk. I almost started crying. But yeah, so we have a couple of questions.
Sure.
Let me read the first one from Professor David O'Regan. This is a profound exploration of end of life. You have used the example of an old man. How does this change in young people? And secondly, what are your thoughts on assisted dying?
Okay, first question, how does this change with young people? I think this is an excellent question. I think when we talk about end of life, right? So I use the dignity model and we talk about that. A lot of the concepts used in the dignity model are similar, right? Because we're going to talk about, so role preservation is just one of those things. But we also talk about things like leaving a legacy behind, what does it mean to pass on as a young person? We also want to talk about things like how does that change your social dynamic as a young person? What does it mean and how do your friends treat you? And why this is important is because then we can come up with conversations, things like when your younger friends visit you, when your peers visit you, they're all in their 20s. Would you like them to be talking about their university experience or not? How would you like them to treat you? Would you like them to still laugh about you? Is it still okay to make jokes? I think this is a really important question to ask. The dignity model helps apply to many different age groups, so I would say that's great. But we have to acknowledge also that a younger death also means that their predisposition to having higher levels of pre-death grief is very real, because there's a sense of injustice, a sense of why is this happening to me, and I would think that makes them at higher risk for mental health issues. So if you do have a younger patient who has a life-limiting illness, almost certainly you should be referring them somewhere just in case, because if they don't have the mental health issue right now, they might want to reach out when that distress arises. So I think it's incredibly crucial to create that referral and that source of support for them. On my thoughts on assisted dying, I think this is a really important question. I think to me, a very big question is what is the conditions that lead to that want of assisted dying? Now, in many cases, I think I'm speaking from my personal view and experience, right? So this is not an empirical thing. I think in a lot of ways, when I go to community, when I go down to the homes of people, I see how loved ones care for their elderly, like those who have dementia and so on. And I see that there's a profound love that is experienced in the middle of that pain, in the caregiving and so on. And I think that until we explore what is the meaning of this phase of end of life for the patient, what are the things that make them want to die faster, we should save the assisted suicide or the hastening of death for a later conversation. We first want to make sure that we fully understand the circumstance. Of course, that gets extra complicated when we talk about immobilizing end of life or life-threatening illnesses, right? Like if we talk about motor neuron disease, that is incredibly difficult. Or we talk about stroke, multiple strokes or so on when the patient cannot move. In those cases, my suggestion would be, I'm not an expert in end of life in terms of assisted suicide or assisted dying. But what I would suggest is, can we think of alternative ways to engage this patient and improve their quality of life? Since in Malaysia, the assisted dying is not that bigly discussed, sorry, not that legally safe to discuss or converse upon, let's talk about how we can engage them with, let's say, sounds like music, their favorite songs. How can we help them draw or use art therapies? Now, on the surface, it sounds like, okay, great, arts and crafts with those who are sick. How does that help? But what it helps with is, imagine if you're immobilized, right? There's so much tension, distress, anger, resentment, all trapped inside. The bare minimum is they can't even ventilate that. So if we can allow them to do that by resonating with, let's say, their favorite songs, or to express that anger, whether it's drawing angry dashes on an art piece, painting everything black, red splotches, that allows for some relief of the stress. So I think there are a lot of areas that we can explore before assisted dying, because we want to make sure that we have explored them. I can't say that I'm fully well thought out and well versed in assisted dying just yet to do a full talk on that, although I've talked a lot. Thanks, Dr. Man.
Yeah, there's another question. Hold on.
Sure.
From Prof. Chan. How long does it take for a keen doctor to develop some of the skills on this subject? You seem to be able to ask/display so effortlessly. Yep.
I think this is a good question. And I think it's a similar question to the reverse that I have experienced. So for example, when I came into the palliative sphere, right, I would get tons of questions like, what is your commitment to understanding disease progression? What is your, how are you going to understand how medication affects the patient's experience? How are you going to understand the different disease progressions and report back to us, the functional status, which ECOG are they on right now? Are they deteriorating? Are they stable, unstable? So what I would say is, it takes time to understand how the concepts interplay in a patient's life, right? When it comes to the skill of developing that empathy, I wouldn't go with the question of how long. I would go with the question of how intentional. The reason why I ask this is because as healthcare professionals, we all have our different specialties, right? So for myself, when I would go into homes, my job would be to understand, am I seeing deterioration in function in the patient? And can I report that back to the team? If there is such a thing, can I ask some basic questions so I can go back to the team and say, hey, I think the patient may be deteriorating. Can you give the family a call and check in and see what's going on? So similarly, when I pose these questions, right, I pose them as areas for exploration so that doctors can identify where the distress could possibly be. Of course, it's a list of questions that I can direct you to help, but the goal should be, once we get these answers, how can we then formulate a plan of action? Can we refer them to a counselor? Can we refer them to a clinical psychologist? Because these skills take time to develop. My biggest takeaway or biggest suggestion would be, if you can get a mental health professional to supervise some of your conversations, they can point out how you can do this more empathetically. So I don't think it's a question of duration, it's a question of intention, and how can we intentionally do that, right? It's like, are we learning just random diagnosis as healthcare professionals, or are we learning about the patient experience of those diagnoses? So that's how I would answer. I don't think there's as clear-cut an answer, but that's the best that I can offer.
Okay, got one more question. Got actually two more, but the next one is from Anonymous. I work with the disabled population, and often their mental health issues are the same as the palliative population. How can I make their healthcare worker encounters less stressful and more meaningful?
Right. Okay. So I think this is of course a crucial question, because it's in the sphere of the sense of helplessness, hopelessness. And when we talk about encounters being more meaningful, so let's say we're talking in the perspective of patients who are disabled, right? What we definitely want to do, so this is also an aspect of, I think, grief therapy that I find very important. So if, let's say, someone has been born with a disability, that's a different question, because we're talking about their lifestyle, what is important to them, what are the ways in which they want to enjoy what they have. But if someone has recently encountered a disability and is now going to continue with this for a long time, what we want to do is explore what does what brings them meaning. So we usually want to know, so for example, right, meaning can be awfully simple. So for example, let's say if someone's going through a disability and the best they can do is wake up, look at the sunrise every day, then we might want to explore with them what are the meanings that they derive from the moments in life that they enjoy. So for example, Miss So-and-so, I notice, you get up every morning and you watch the sunrise. I wonder, why do you do that? And, she might say something like, oh, I like the colors. And we might say something like, oh, why do those colors mean so much to you? And they might say, it reminds me that every day there is something beautiful. So we want to focus on creating those moments. So I like this term. We call them sometimes, if I'm not wrong, glimmers. So even if we can't expect sustained joy, what we can help to do is create glimmers of meaning in the patient's experience. So whether that's exploring the little joys that they experience throughout the day, or exploring the lifestyle that they want to continue appreciating. It's of course a complex question, and I love to be in touch because, of course, the people that you work with, it's very challenging. Yeah, that's a little tidbit that I can, I guess, suggest with my limited time.
Yep. And one last question in the chat box. Well, what aspects of a patient's ethnicity or culture would you choose to focus on palliative care mental health?
Wow. Okay, this is a fantastic question. So I love it. I love it because we are Malaysia, right? So that means everything is diverse all the time. So the biggest question when it comes to exploring culture, right, and understanding how that influence culture and ethnicity, I think it's always important. So even in psychotherapy, right, we are always asked, how can we consider how the patient's life impacts their current situation? Life is a pre-existing condition, right? We had life before we got here. So the question that we normally want to have in mind is sometimes we can just straightforward ask the patient, oh, by the way, I know that you have shared with me that you profess to Hinduism. I'm wondering, how do people in the Hindu faith see end of life? And they might tell you, I believe it's just another phase, reincarnation is what's coming next. And then you ask, so how does this belief affect how you see your final phase of life? What does that mean to you? So we want to make sure that we explore that intentionally. Of course, when we talk about cultural and ethnic differences, that also means we need to know the basics of beliefs of each different culture when it comes to the end of life, right? What is the importance when it comes to making sure nutrition is adhered to? Are there some cultural issues with not feeding a patient? Is that perceived as to disrespect your elders? So I think that's important to know beforehand, but if you're not aware of it, it's important to intentionally ask. Usually we are afraid to ask because we're afraid to offend. So my suggestion is come from a place of curiosity. And if the person is upset with you for whatsoever reason, don't worry about apologizing. Say, oh, I'm so sorry if I offended you. I was just curious because I want to learn more about you and I want to understand you better. I think we shouldn't be afraid to be curious and at the same time, not afraid to apologize if we need to. I think it's a part of understanding someone, right? Being able to ask and to apologize. So spirituality, cultural effects, highly suggest searching the basics and then making sure we check with the patient. Sometimes, although their culture might say one thing, the patient just might not care. So it's good for us to check. A whole other topic, but I do have some people that specialize in it that I would connect you to if you wanted to know more. Yes, thanks, Dr. Mike.
Yep. Okay. I think that's all the questions we have in the Q&A and chat box. If you have any more questions, you have Ethan's email address and number there. And I want to thank him for a very interesting and profound talk. And thank you for everybody else who've attended. Yep. And let's end it. Yep. Okay. Thank you.
Thank you for having me.